Welcome to our session on durable medical equipment for children and youth with special healthcare needs. I'm Laurie Soman. I'm Senior Policy Analyst with Lucile Packard Children's Hospital, Stanford Children's Health, and I also direct CHRIS, a 29-county collaborative of county CCS programs, family support organizations, pediatric organizations, and children's hospitals. And we have a goal of promoting a more effective, efficient, and family-centered CCS program. So access to durable medical equipment is a topic of long-standing interest for both CHRIS and for Family Voices. For example, both our organizations have done multiple surveys over the last 15 years, asking families, providers, and counties about their experiences with access to durable medical equipment, particularly barriers to access. A major one being, as you all know, families being forced to pay out of pocket for durable medical equipment for their children. So today we have three wonderful speakers, all of whom have a lot of experience studying and living the world of access to DME for children and youth with special healthcare needs. And it's my pleasure to tell you a bit about each of them. Alicia Emanuel is a senior attorney in the National Health Law Program's LA office. Her work focuses on California and federal health policy with an emphasis on Medi-Cal and covered California advocacy. Before joining NHeLP, Alicia was a senior policy associate at the Children's Partnership, where she worked on health policy and administrative advocacy for low-income children at the state and national levels. And prior to that, she was a staff attorney at Legal Services of Northern California, where she provided education and advocacy to healthcare consumers in 32 California counties and represented clients in Medi-Cal, covered California, and private insurance hearings and appeals. Then we have Anna Leach-Proffer. Anna is an associate managing attorney with Disability Rights California. She's a member of DRC's Healthcare and Home and Community-Based Services Practice Group. She advocates on behalf of individuals with disabilities through individual representation, policy advocacy, and impact litigation. Her work includes a wide range of Medi-Cal issues with a particular focus on Medi-Cal waivers, California Children's Services, which we call CCS, and the In-Home Supportive Services, or IHSS program. And then we have Janna Espinoza. Janna is from Salinas, where she is learning how to navigate and thrive in the world of involvement with her family. Her youngest, Coraline, and I apologize, Janna, I should have asked you how you pronounce your daughter's name, so please correct me if it's not Coraline. Coraline has epilepsy, cerebral palsy, severe hearing loss, a delightful laugh, and loves to paint. Janna serves as the chair for Central California Alliance for Health's Whole Child Model Family Advisory Committee, can push a wheelchair and drag a shopping cart at the same time, and likes to embroider. And Janna brings another unusual and really valuable experience to the mix here. She has lived in and experienced CCS in all three kinds of counties. She's lived in a classic CCS county that was large and independent, a classic CCS county that was small and dependent. And if she needs to, she can explain that. And now she lives in a whole child model county. So she kind of covers the waterfront in terms of experiences with CCS. So I believe we're going to start with Alicia and Anna, who are going to kind of tag team this PowerPoint. So take it away.
Hi, everyone. This is Alicia Emanuel, and thanks for the warm welcome and introduction, Laurie. As Laurie said, I work at the National Health Law Program, or NHeLP. Anna, you can go to the next slide. We are a national public interest law firm that works to advance and protect the health rights of low-income and underserved individuals and families through education, advocacy, and litigation. Next slide. And one of my co-presenters is Anna Leach-Proffer with Disability Rights California, a nonprofit organization founded in 1978 that defends, advances, and strengthens the rights and opportunities of people with disabilities. Next slide, please. today we're going to go over the basic structure of the California Children's Services Program, or CCS, and Medi-Cal, and how to access DME and medical supplies through both programs. And then we'll get to hear from Janna Espinoza about her experience supporting her daughter through the system. Next slide, please. We wanted to let you know that the National Health Law Program published an issue brief titled "Helping Families Obtain DME and Supplies Through the CCS Program." This is designed for advocates and family members alike, anyone that needs more guidance and assistance accessing DME and medical supplies. On the right of the screen is a link to where you can find the issue brief. And the latest version includes some COVID public health emergency specific tips that might help you to access the services you need. This was generously funded by a grant from the Lucile Packard Foundation for Children's Health in Palo Alto, California. Next slide, please. Okay, let's talk briefly about CCS. So those of you with children on the CCS program or who support and or are advocating for kids on CCS know that it provides diagnostic and treatment services, medical case management, and physical and occupational therapy services to children up to age 21 with a CCS eligible condition. Qualifying conditions are serious and severe physical disabilities and complex medical conditions. There's roughly 200,000 children on the CCS program, and many of them require access to DME and medical supplies. Approximately 70% of children on CCS are also Medi-Cal eligible. So that means that advocates and families, CBOs who are supporting children enrolled in both programs must navigate the interplay between the two. Next slide, please. Traditionally, the Department of Healthcare Services and county health departments have administered the CCS program. But starting in 2018, the Whole Child Model Program was implemented through a 3-phase process that changed who administers the CCS program in 21 of California's counties. As a result, responsibility for CCS program administration now depends on the county in which the child lives. Next slide. This slide shows a chart outlining that 3-phase process of the Whole Child Model rollout by county. Essentially, in these Whole Child Model counties, the Medi-Cal Managed Care Plan is responsible for providing comprehensive care coordination and integrated services to Medi-Cal eligible children on CCS for both their CCS eligible and non-CCS eligible medical conditions. Next slide, please. And you can advance one more. Thank you. So just real brief, this slide just shows a chart of the basic structure of the Medi-Cal program. The bottom right is the most important. Children on Medi-Cal will either have fee-for-service Medi-Cal, sometimes known as straight Medi-Cal, or they will receive their care through a Medi-Cal Managed Care Plan, and that's where you're going to be accessing the DME and medical supplies for the child. Next slide, please. So let's get into this here. The threshold question of whether or not CCS or Medi-Cal will cover durable medical equipment or medical supplies is whether or not it is deemed medically necessary. This slide shows two different standards, one for CCS and one for Medi-Cal. The CCS program only covers DME and medical supplies when they are medically necessary to treat a CCS eligible condition. According to the DHCS guidance, medical necessity for CCS is defined as a limitation of a mobility or a self-care skill related to a CCS eligible medical condition, which is verified by physical findings and which justifies authorizing DME. That's a mouthful. However, on the right, you see something that says EPSDT. Under federal Medicaid law, the medical necessity standard is different. The early and periodic screening, diagnostic, and treatment standard, also known as EPSDT, applies to all children and youth under the age of 21. And it requires that everything is covered that is necessary to correct or ameliorate defects in physical and mental illnesses and conditions. This is a much broader medical necessity standard than the CCS DME standard. Families and advocates should be aware that the CCS medical necessity definition might be too limiting to effectively treat certain CCS conditions. And the key takeaway we want you to take from this slide is that for CCS beneficiaries with Medi-Cal, the broader EPSDT medical necessity standard must apply. And I am going to pass it over to Anna. Anna?
Thanks, Alicia. Again, my name is Anna Leach-Proffer, and I'm an attorney with Disability Rights California. So I am going to take over here and talk a little bit about how the need for DME and supplies can be initially identified. And those needs can be identified by a range of providers in a variety of settings. For example, a child's need for DME could be identified by a treating doctor, either a primary care physician or pediatric or other type of specialist. It could also be identified by an educator or provider at the child's school, or maybe perhaps a provider in the MTU, medical therapy unit, that the child attends could identify those needs. Or for children who are also consumers of the regional center, it could be identified by a regional center provider as well. And I did want to note that in cases where it's a non-CCS paneled physician who's identifying the need for the DME or supplies, that child would then need to get a referral to a CCS paneled physician who could then submit the request to CCS for the authorization. And the brief, the issue brief that Alicia shared earlier does have some more information about sort of how each of these types of providers might go about identifying those needs. And so now I'm going to move into accessing CCS DME. So once the need for a piece of equipment is determined, and it's determined to be medically necessary under the standards that Alicia discussed a couple minutes ago, there are still, unfortunately, a number of criteria that have to be met in order for that piece of equipment to be authorized. I'm going to talk through those quickly. They're also here on the slide. So there must be prior authorization. I did want to take this opportunity to raise that during the public health emergency, there have been a number of flexibilities put into place by the Department of Healthcare Services that were approved by CMS, by a federal agency that oversees Medicaid. And as part of those flexibilities, there have been sort of some lessening of the requirements in terms of what needs to receive prior authorization. And Alicia just put into the chat here a link to a fact sheet that was created by NHeLP and Family Voices titled Access to Care Through CCS During COVID-19. And that discusses sort of more of the specifics on what flexibilities were put into place during the public health emergency and how those impact CCS. The second additional requirement is that the DME must be the lowest cost piece of equipment that will meet the need. Oh, and I did just want to note quickly, I'm sorry, that the publication that Alicia linked to is also available in Spanish and Chinese. And the prescription the piece of equipment must be prescribed by a CCS paneled physician, and it must be within their scope of practice. The fourth requirement is that there must be a face-to-face encounter with the CCS beneficiary before prescribing the DME. Again, this was not required during the public health emergency as part of those flexibilities, although we anticipate that a requirement will probably return when the public health emergency ends. Lastly, the DME must be portable, which means it cannot require installation. And I did want to note again here that for Medi-Cal beneficiaries, the EPSDT standard should apply when making these determinations. So what you're seeing here on this next slide is a bit of a flow chart that shows how children will access, how CCS children will access DME and medical supplies by answering a series of yes or no questions. As you can see, for children that are not in a whole child model county, they will, regardless of Medi-Cal status, be accessing DME through a CCS county or regional office. And Laurie sort of mentioned this earlier, but for these non-whole child model counties, it's the population of the county that determines who administers the program. So in counties with populations greater than 200,000, the county is responsible for independently administering the program, and these are often referred to as independent counties. And then for counties with less than 200,000 population, they're referred to as dependent counties. And in those counties, it's the Department of Healthcare Services, or DHCS, that administers the program, including providing medical case management and making eligibility and benefit determinations. In whole child model counties, the access will look a little bit different depending on whether the child is also a Medi-Cal beneficiary. And as Alicia mentioned earlier, about more than 70% of children who have CCS also have Medi-Cal, so it's going to be the vast majority of those in the CCS program. And so children who have Medi-Cal will access CCS DME directly through their Medi-Cal managed care plan. And for children in whole child model counties who do not have Medi-Cal, they will access DME through the CCS county or regional office, just as children in a non-whole child, all children in a non-whole child model county would. I want to mention quickly that for children with other healthcare coverage, which is most often commercial coverage through a parent's employer, things are even more complex, as if it wasn't complex enough. And a few things, sort of concerns to remember for children who also have private insurance is that in order for CCS to authorize and pay for the DME, the child is going to need to see a CCS paneled provider. And that can sometimes be challenging depending on whether the child's, if they're in an HMO through the commercial coverage, depending on whether that practice has a number of CCS panel doctors or not. The other thing that comes up, and I see this quite a bit in working with individual clients, is that CCS is typically the payer of last resort, which means that they will not pay for a particular service or piece of equipment unless that service or piece of equipment has been denied by the private insurance. And CCS often requires that there be a copy of that denial, a written denial, submitted as part of the process, their own authorization process. And what I have found is that this can create delays and barriers to the receipt of much needed DME. And what we're hopeful for as advocates is that the Department of Healthcare Services can issue additional guidance on how to navigate the CCS approval process when children also have other healthcare coverage. We're hopeful this can involve an increase in flexibility. And one example is perhaps allowing just the evidence of coverage as proof that a particular item is not covered rather than requiring a specific written denial. So I've dealt with situations where it's very clear from the evidence of coverage that a particular piece of equipment is not going to be covered by the plan, but yet we still have to go through the process of getting them to issue a written denial, which can be time consuming. In particular where the equipment is, the need is more urgent. So again, this is an issue that's touched on in the NHeLP issue brief, so you can also take a look there. Okay, so now what I want to talk about is the appeal process when you want to challenge a denial of DME or medical supplies. Now, of course, in an ideal world, all necessary equipment that's prescribed is going to be authorized, and we can just work on, kind of moving that approval through and making sure that we get the equipment. But we all know in the real world, it's not that simple often. So I want to talk a little bit about what the process looks like if a piece of equipment is denied. And I do want to note for beneficiaries of both CCS and Medi-Cal, both of these processes should be available for any given decision. Negative decision. Just quickly here mention key elements of each of those appeal processes. So for Medi-Cal, a written notice of action is required for any negative action. There is always a right to a hearing with a negative action. And in Medi-Cal, in most circumstances, there is access to aid paid pending, which means if a service has been reduced or terminated, that it can continue pending the outcome of the appeal. And for CCS, on the other hand, a notice of action is not always required. And beneficiaries do not, in fact, actually always have the right to appeal a negative decision. And the process for trying to get a service continued pending an appeal is much more complicated. It's multi-stepped and not guaranteed in the way that aid paid pending is guaranteed for Medi-Cal appeals. So you're probably noticing that the appeal rights are much more robust and beneficiary friendly in the Medi-Cal appeals process. So this is sort of why in my role as an advocate, I often recommend that families, we can pursue both appeal processes, but we often make sure if they're a Medi-Cal recipient that we definitely want to pursue the Medi-Cal appeals process. And next, talk a little bit about the timelines, because these processes also have different timelines for filing an appeal. I'll talk about Medi-Cal first. So in Medi-Cal, the timeline for filing an appeal will be a little bit different depending on whether the child has fee-for-service Medi-Cal, sometimes called straight Medi-Cal, or is in a Medi-Cal managed care plan. So in fee-for-service, the beneficiary has 90 days from the date of the notice of action to appeal and ask for a state fair hearing. And they are entitled to aid paid pending if the appeal is filed within 10 days of receipt of the notice of action. Here on the slide, it says the date that the denial was mailed. We often advise families to try and appeal by the date on the notice, just to ensure that there's no question about your aid paid pending. But technically it is from the date you received it. And in my experience, often like 3 to 5 days for mailing is not an issue. And then sometimes, beyond that, we can run into a little bit of a problem getting the aid paid pending. So the general advice is just to try to get that in as soon as possible. And in a managed care plan, works a little bit different and follows the managed care grievance and appeals process. So the initial appeal must be filed within 60 calendar days from the date of the notice to appeal. That appeal goes directly to the health plan, which then has 30 calendar days to make a decision, or 72 hours in certain pretty narrow circumstances where it's an expedited appeal if the beneficiary's life or health are at immediate risk. And then if that decision from the health plan is not favorable, the beneficiary then has 120 calendar days to request a Medi-Cal state fair hearing, which would basically feed into the exact same process that the Medi-Cal fee-for-service appeal would get you to. And now I'll talk about the CCS appeals process. So the CCS appeals process starts with what's called a first level appeal, and that has to be filed within 30 calendar days from the date on the notice of action. That goes to CCS, the county CCS, or in the case of dependent counties, it would go to DHCS. CCS has 21 calendar days to send a written response. Or if they deem that there's not sufficient information available, they then have 21 days from whenever they receive the information that they've requested. And then the next phase of the CCS appeal process is where the timelines really get tight and where I see a lot of families missing those deadlines. So with the next level of appeal for CCS, you only have 14 calendar days from the date of the written appeal decision to submit a request for a CCS state fair hearing, which is different from a Medi-Cal state fair hearing. And again, there's some extension if the beneficiary is notified that they will need to submit additional information. But you will note that this is a very short timeline, so often one that I want to make sure that families are aware of at the point where they're filing that first level appeal, and can really be watching for that written notice to come in and sort of be prepared already to get in the second level appeal for the CCS state fair hearing. And then before I turn things over to Janna to talk about the family experience, I just wanted to let folks know that here on it's slide 22 of the presentation of contact information for the Health Consumer Alliance, as well as for my organization, Disability Rights California, the numbers for our intake line. So both the Health Consumer Alliance and Disability Rights California provide direct services in the form of advocacy and representation to clients with CCS and Medi-Cal questions and issues. So those are great phone numbers to have in terms of resources for reaching out and talking through your situation and seeking representation. There's also a link at the bottom here to the Department of Healthcare Services CCS advisory group. And that's a group that I believe is still meeting quarterly, and these are meetings that parents and advocates and providers, a wide range of folks can join and hear updates from the Department of Healthcare Services. And also there's an opportunity for public comment to raise issues that they may be seeing. So with that, I'm going to go ahead and turn it over to Janna to talk about the family experience. And then when we get to the end, Alicia and I will both be here to answer any questions that folks may have.
Awesome. Thank you so much. So my name is Janna. That is my daughter, Coraline. She's really awesome. I think that we already kind of touched base on this, but I have an incredibly unique experience. Cora was born in 2012. And so when she was born, she had some complications, and we were in the world of regular olden timey days CCS. And we had challenges with CCS, but it was kind of a learning experience. So that was really positive, but we had some really negative experiences that I'd be glad to tell you guys about as well. Can I get the next slide, please? Excellent. So I know most of you guys probably already know what DME looks like for the families that you work with or for your own family, but specific to my kid with her constellation and Scrabble bag of acronyms, these are the kinds of things that we regularly have to use. And I think that one of the things that was hard for me at first was having not just one place that's providing the DME that we need on a daily basis. So we were like in completely different arenas, completely different places. And so each one of these places was just one component or one part of what Cora needed to be able to access life in the best, most positive way possible. Can I get the next slide, please? So I think one of the things that's most important when it comes to this is knowing who is there for you, knowing who is in your corner, knowing who you can go to. For myself, I find myself incredibly lucky, and I'm incredibly grateful that I have a medical therapy unit that has been incredibly awesome in the way that they've managed DME supplies for my child. We have if you are in a county that has a whole child model, or if your health plan has whole child model, we all have family advisory committees. These are all people that are on the same page as you. These are all people that know the world and can help you navigate the world. Your regional center is a great place where they know what they're talking about, and they can be incredibly awesome advocates. Your school districts, your Office of Education, Early Start infant program. For some of us at the beginning, when you have a kid with complexities, you a lot of times have a person that comes to your house. And we were lucky enough to have a really good infant program that really did a great job laying the foundation and the framework for further care for Cora. We can go to local parent-led supports. You can communicate with your local legislators. Because of Family Voices is the only reason that I know just how absolutely willing legislators can be to talk to you about what the needs of their constituents are. So that was something that was incredibly helpful for me. And for those of you that have whole child model, you also should have, hopefully, a nurse case management system set in place, or a care coordinator that can assist you with DME stuff. The only thing about who is in your corner, most of these places, you're not having to do any training, and you're not having to explain how things work to somebody else. So the therapy unit, they know what they're doing. They're very competent in what they're doing. Vendors, they know what they're doing. Our regional center, they know what they're doing. But with the whole child model, one of the complexities of that is that it becomes the responsibility of families to do training. And so when you're trying to access DME, but at the same time, you're also having to train the people who are communicating with the insurance plan, that can absolutely take away valuable time that could be spent getting the access for your child. However, one thing that's nice too is that we have kind of a up and down with that, because if you're patient enough to help with training for your case managers, the positive thing on that is that any time that you spend trying to help make this familiar to your care coordinators, all that's going to do is cascade into something positive for another family. So anytime that there's anything that can be really, really frustrating, or it's driving you crazy, the thing that I have found is if you just try to go with a vibe of, okay, this really sucks, but it'll suck really bad for me right now, but hopefully what I'm doing right now that's not working, hopefully that means that the next family won't have to deal with the same sort of issues. So that definitely has been, for me, a little bit more challenging, especially at the beginning of having whole child model. I remember calling, I was having issues with audiology, and I called to speak to my case manager, and she told me, oh, here's the phone number to Stanford Children's Deaf and Hard of Hearing stuff. And that was the supports that I was given when I was having some DME issues. So there were definitely some growing pains, and I think it's well worth spending a decent amount of time kind of just familiarizing your case manager with the needs of your child, just as a matter of course. If I could get the next slide, please. So for me, these are the things that have helped in the past. I have, like I was mentioning before, we have a lot of different vendors that we use. We have a lot of different places that we have to go. For me, I found that making an obnoxious level of record is the absolute best thing you can possibly do. Making sure that you have times always written down, who you talked to, what was going on, what you talked about. I usually have a binder with tabs, and that helps me to organize my records. You can put in your receipts, your shipping notification, notes from records, anything and everything. Just put it all in one place and have it kind of set up in a way that's just going to help you as you go. An Excel sheet for some people might work. It doesn't work for me, but I know the other people that has been something that's worked well. One thing that helps me quite a lot, especially since for DME, we're dealing with G-tube supplies. So not just stuff that's like wheelchair related. So we have certain things have to be ordered by a certain date, and not everyone has auto order. So the thing that's nice about creating a calendar event or an alarm is it's a really good way to make sure that everything that you get is done in a timely way, and you're not like, life is wild for all of us. So sometimes things can get away from you. And personally, that's been something that's been really helpful to me. And then if I can get the next slide, please. So one thing that's Cora. One thing that was helpful for me, again, like I said, I'm incredibly lucky. I have a medical therapy unit that has been incredible in helping to find things that work best for my child. And because of the cost of these devices, one of the ways that you can find out if something's even going to work for your child is a lot of times at the medical therapy unit, they will have samples or things that are dropped off by the vendors to try out for the kids at the medical therapy unit. Personally, we've had some equipment that we've gotten from other families donating items. And for us, now that was done for us, our go-to is every single time our daughter outgrows a piece of equipment, we immediately donate it to the medical therapy unit so that it can be used for another child if needed. And for some of us, it can be incredible. And it was such a great way of seeing what benefit these types of things can have for your child. Also, you can work with your school district. Sometimes your school district might have some devices that you haven't ordered yet that you might want to try out. And that is another resource that might work for you when you're trying to manage this sort of work. Can I get the next slide, please? So I'm sure most of us already know how silly this can be, but when we're talking about medical necessity, you could have the medical necessity of needing a piece of equipment for feeding, like a feeding chair. You could need one as a seating device, or you could need one as a mobility device. So for CCS, they consider my daughter's wheelchair to fill all three of these things. So her wheelchair, they're not going to pay for a seating device because they say she has one already. They're not going to pay for a feeding chair because they say she has one already. And they're not going to pay for wheels on anything else because she has mobility with her chair. So for instance, we had a dynamic stander that our daughter had a prescription for from CCS when we had a clinic appointment. And unfortunately, we weren't able to get wheels for it because that would be considered a mobility device once the wheels were on it. So what we would have to do is we would have to go and find grant funding from somewhere to be able to pay for those wheels. I think maybe the next slide, I don't remember which one is that. Oh, okay. So yeah, definitely for us, a big thing was using grant funding. We were able to get something for feeding via local grant funding, and we were able to get wheels for a stander through Children's Miracle Network. One time we worked with the medical therapy unit OT to help us with our grant request. And then I had the infant program help us with the other one, and they were able to help source what would be a good direction for us to go. So one of the things that's been the most challenging in my daughter's life, we lost our housing during COVID. I formerly am a substitute teacher. I have a high-risk child. So with distance learning, not needing subs so much, and then also the risk to my child, I haven't been able to work besides in-home support services. So we became officially homeless, and my mom lives in San Benito County. I lived in Monterey County. The Alliance covers Monterey County, Santa Cruz County, and Merced County, but does not include San Benito County, which is in between Monterey and Merced. So San Benito County is a dependent county, or independent. Is it dependent? Yeah, I think that's what it's supposed to be called. But they don't even do authorizations in-house. All of their stuff is sent down to LA, and then they get it back up again to them in San Benito County. And the way that this worked incredibly negatively for my family is that we lost everything that we had. We had nothing, was like none of her DME stuff was able to come in. She had G2 supplies that took me 30 days to get sorted out because they're allowed to have those amount of days. So I'm just for the first time was seeing the 72 hours if life is at risk. And I would think not having food for your G-tube is definitely not so fantastic. So we were having to do a lot of reusing of equipment, reusing bags, and it was really, really frustrating. I made several hundred calls. Department of Healthcare Services is the people that are supposed to be in charge, and they gave me different information, every single person that I talked to. My daughter has Social Security, so she has Medicaid. Her Medicaid is managed through Social Security, but it's then assigned to a specific county. So we had Medi-Cal through Monterey County. San Benito County took over, and yeah, like I could literally have like a whole breakaway session to talk about like how ridiculous it was, but just there are huge, huge gaps in communication. San Benito County, I asked them, every time I talk to them, I'm like, have you talked to anybody from Whole Child Model? Have you talked to anybody? Like, has there ever been another family that's moved from one county that has Whole Child Model to your county? And they're like, well, no, not really. We haven't seen too much of that. And then I offered that same question to the Alliance, and they didn't really have much experience in that either. So what I was dealing with was something that in every single place I called, they hadn't ever dealt with it before. And the end result of that was my child wasn't getting the care that she needed. And I was having a really hard time accessing any reliable information. And it took me about 6 months to get everything sorted out. And we're just now back to baseline. But it was pretty horrific. And I just can't help but think that I look at the city that I live in, and I look at my peer group, and I know that we're not the only people that have had to go stay with another family member. I know we're not the only ones. So if you have a family where there could be immigration involvements going on within the household, you're not going to fight these things in the same sort of way usually, from what I've heard from people, just so much that we don't always want to open our lives completely open. Like I literally at this point of life, like I would be fine giving every single one of you guys my Social Security number right now. Like my life is completely open to everybody. And for some people that can be incredibly challenging when there is other things going on within their household. Or sometimes I know that I have been, but like sometimes you can be scared that you're going to have CPS called because of what your living situation is like. Or if I think you guys all kind of know the direction I'm going with this, but yeah, just that we're incredibly vulnerable, and we have some segments of our population that's especially vulnerable and especially put into a place that's incredibly challenging. And just because there aren't people filing appeals, or just because there aren't people filing grievances, don't mean that they don't exist. It just means sometimes people don't know what rights they have. And so that for me was incredibly challenging doing this, especially looking at my peer group, looking at the people that are on my family advisory committee with me, looking at the other families. And I just, yeah, like I said, I could do like a whole entire panel, just me complaining about all the things that that have not gone so great. But I think that what I would hope is that from everything that I had to deal with, I'm hoping that by bringing it up to my Whole Child Model Family Advisory Committee and my nurse case manager and the regional operations director for my insurance plan, I'm hoping that that means that there will be more back and forth and more communication when you have a situation like what happened with my family. So the communication between counties, agencies, and healthcare systems are not what they could be and not what they should be. People are not getting the services that they should be getting in a way that's best for their families when there is not appropriate communication within the different systems. And then the next one, I believe, I think I'm on the last one with that next one. Yay. Okay, so for this one, there is Cora again. it's ideally, it would be super great if all you had to do was file an appeal and you would get what you needed to get. That didn't work for me. And I know that maybe doesn't work for other folks. And then for us, with one of her DME needs being feeding supplies, you don't have 30 days where you can just be like, okay, cool. Yeah, no, I'm fine. In 30 days, everything will be worked out. No, like your kid needs to eat. Like you don't want your child to die because they can't have access to things. So, and again, in an ideal world, I understand that hopefully you would have those things taken care of within 72 hours, but that's not the experience that we had at all. So if you can't get the supplies you need, I think that a lot of us understand that there's a little bit of hustle involved in having a child like we do. And there are Facebook groups that do buy, trade, sale for DME supplies. It sucks to pay out of pocket, but sometimes that's what we have to do. A lot of times you can get bags or extensions or whatever it is that you need to get, or if there's ventilation supplies that you need, you can do it that same sort of way. You can call your provider directly, tell them the issues that you're having, and a lot of times your clinic will be able to find a way to get you the supplies that you need to make it through until you can get those ones covered. You can go to your local children's hospital. You can call them first, of course, but tell them like, hey, I can't get these supplies. What should I do? Because for us, we can't do that locally. In the past, now we know we have to bring every single bit of supplies that my daughter is going to need to our local hospitals because they don't have those supplies. We have had to go back to our house to go bring more supplies to other families that were at the hospital that had the same needs that we did, but they also couldn't get those devices or those supplies so that they could have that hospital stay. So I think that I'm seeing Daisy, absolutely. Daisy is saying in the chat that the Facebook local groups can also be incredibly powerful. And absolutely, I totally agree. Also, your family regional center might be good. I would call again and again to your insurance plan, but we have a lot of things available to us. But the thing that's really hard is we can't get the answers when we don't give the questions. So yeah, if we're all in this together, I think that anything that I can get from another family that's dealt with something really intense, I appreciate that we have such an awesome group of advocates that are my peer group. And I thank all of you for being loud so that I didn't have to be loud sometimes. And thank you for the efforts that you've made to take care of your child, because it also has taken care of my child. So thank you.
Well, thank you, Janna. I want to say a couple things about this. First is obviously, thank you so much for being willing to talk about this, to take us to the on-the-ground experience, and being willing to share what clearly is just a painful, difficult experience. The other thing is, thank you for reminding everybody that it takes a village, and we are all part of that village. I also want to just touch on a couple of things that you commented on during your presentation. First is, I noticed, and this is a really common thing for women to do, to refer to yourself as being obnoxious or angry or pushy or something. That's us being advocates. So let's just own that that's what it takes to be advocates, and that's what we'll do. So I totally honor you for that. Go right on being all those things. The appeals and grievance issue, we always say this to families. It's easy for us to say it. Please file a grievance, please file an appeal. We know it's really difficult to do that, but we also know from talking to people at the state level that they are not seeing a lot of appeals and grievances. And I think that there's a tendency for them to measure their success by the number, hopefully a low number of grievances and appeals, but that's not actually registering what's happening on the ground. And I think everything you said is proof of that. So I don't know what the answer is, except to remind family members who are in this session that your local family support organization can help you file grievances and appeals. And obviously around DME, you've got NHeLP and disability rights to help as well. But painful as it is to file appeals and grievances, If that's how success is being measured, we need to be sure that the state is aware of where there are problems. The other thing I wanted to mention is you talked about how you created a child health binder for Cora.
Yeah.
There are good models available online, both for hard copy child health binders for kids with special healthcare needs and electronic versions. And so if families need help finding those, I think I'm going to kind of like, throw Allie and Family Voices under the bus. I know Family Voices can help identify some good models, but local family support organizations also may have them where some help in constructing a hard copy or an electronic version. So I think that's really important, particularly in your experience where you obviously had to carry that around with you to 3 counties. So
I had two binders.
There you go, 2 binders.
Before, so that it doesn't get lost. I don't know if I had mentioned this part, but I'm seeing something that Daisy wrote in the chat. She's communicating that in Northern California, we have Able Closet for a resource for DME. And so essentially my understanding is it's like a library where you can they have these really cool wheelchairs that can go on sand. So sometimes they'll have something like that and you can go, I believe it's in Santa Clara County, and can not rent, but check things out. And I think that is a really great way for people to find out if something is going to work for them. This might be what works for them. And I also wanted to again say that I really think that a lot of the time that we're not having grievances, I do think that people that are monolingual are a heck of a lot less likely to file a grievance. And Placer County, cool, thank you. But it's a wild world out there, and I'm glad that there are so many others that are allowed. And I do take the being obnoxious as a positive trait. That's not a negative thing. I'm saying that is something I own, and I am 100% okay with that.
Great. Well, as one obnoxious woman to another, yay. So I know we don't have a lot of time left for questions, but given how complex the process was that Alicia and Anna described, and then your on the ground experience, Janna, I'm wondering if maybe we can just lead with asking Alicia and Anna, and then Janna, if you have anything to add to that. How can families access legal help to support them when they really need that to get access to DME?
I can jump in first and then Anna can. This is Alicia speaking. Thank you again, Janna and Anna, for presenting. It was, I think, really informative to all of us on the call to hear Janna's personal experience. I would just reiterate, maybe Anna, you could go back to the slide with the HCA and DRC contact info. Because Janna astutely pointed it out, I want to call out that both of our organizations are nonprofits. We're not affiliated with the government. We are there to help people, and we provide the assistance for free. And we have translation services available. So people should feel free to call either of these numbers. And I should have clarified that my organization, NHeLP, is part of the Health Consumer Alliance. We function as a support center to that essentially consortium of legal aid programs. If a case goes through there, I will likely be helping to work on it. So please do reach out. I completely understand from what was noted in the chat that there are other times and oftentimes other life priorities that come up, but just consider this as an additional support to that list Janna provided of all those people that can be in your corner.
Yeah, absolutely. And this is Anna. So, I mean, just want to second everything that Alicia said in terms of Disability Rights California. So if you call our intake line, all of our sort of frontline intake folks are bilingual in English and Spanish, and we have advocates and attorneys who speak Spanish, and then we have some other language access here and there, and we can use Language Line or other services to talk with folks in any language. But I kind of talked about this a little bit with Janna, unlike some other areas of law that I practice in, I mean, these CCS cases is often where I find my role as sort of being that squeaky wheel for families when, you know, they can't be. So being the one who's kind of keeping the timelines organized and, okay, let's file this appeal and we're going to call your private health insurance, you know, every, you know, 2 times a week and make sure that they're getting us that written denial. And then we're going to make sure that CCS received the fax that we sent, and, you know, sort of managing some of those types of things because, you know, as Janna mentioned, I mean, as you know, as a lawyer, I'm sort of limited in what I can do in terms of immediately fixing something. So I was actually super excited to hear about the ABLE Closet and some of these other resources because it's, you know, I hate saying, okay, great, we got your appeal filed. Like, let's wait our 30 days or 21 days. And, you know, but there's, you know, little I can do in terms of meeting, you know, the immediate needs. So I see it as sort of like a partnership and one that I would like to grow with some of these other community, you know, based organizations in terms of, okay, we can handle these legal appeals for you, but we know that's not going to meet the immediate needs. So how can we better connect folks with, you know, ways of meeting that need? So I think I would really encourage folks to, you know, call our organization or call the Health Consumer Alliance or, you know, call us both. We can't take every case that we get for full representation, but we can provide advice and guidance. And I know personally, anytime I see a CCS case on our intake log, I really try to take it if I have bandwidth at all. So just want to encourage folks to do that.
Thank you, Alicia and Anna. And Janna, we have about a minute left. I'd be interested if you have anything that you could add to how families can get help when they have legal questions or need access to legal advice, or any other comments you'd like to make to close us out before we go to our formal closing.
I think, well, one thing that I'm really glad that these resources are available here, because in the past I have tried to look for a lawyer for issues related to this kind of stuff, and I couldn't find anybody that was willing to take a case. They weren't taking on any new clients. So I think being able to have these sorts of resources are incredibly important. And I just think that the more, even if it's not something that I would necessarily use, I know now, like, hey, so-and-so mom's having this issue, so-and-so dad's having this issue. And it's really nice to be able to have this kind of stuff available. We're all in it together, and whatever we can learn from other folks and whatever we can learn to get us all what our kiddos need to get, then I'm all about that.
Thanks, Janna. And I'm proud and pleased to be in this village with you and Anna and Alicia.